O senhor não está vendo a câmera?
Okay. Are you seeing, guys, the whole screen?
Yes.
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 Okay.
Yes. It's fine. It's good.
Okay, so it's a great pleasure to be here tonight in this Vascular Neurosurgical Week from the Brazilian Society to cover a very challenging topic, which is neurosurgical management of brain AVMs. I'd like to start telling about my disclosure. My disclosure is this strong professors and mentors team that I had the privilege to be with for some part of my life. First, my great mentor, Professor Fernando Braga. As Paulo said, I had a chance to see Professor Yassergil with him in Little Rock. Also, Professor Spetzer during my fellowship at Vero. And then when I go back to Brazil, I could spend some time helping Professor Byjean De Oliveira in his lab courses. And all those guys inspire me to try to help patients with AVMs. So, of course, I cannot forget my dear friend Michael Lawton, who has the largest experience with this kind of lesions. So he is a great good friend and also a professor where we can always learn something. And of course, this guy is my everyday mentor. Sometimes he's my boss, sometimes he's my friend, sometimes he is my older brother, but it's independent how he is, he's always around. So it's always good to have his support. And going direct to our point tonight, my lecture was prepared for focus on the residents, the young generation of neurosurgery. So I'm going to try to cover the basics aspects of the AVMs. These kind of lesions are classified along with cavernous malformations and telangiectasias and genus malformations. A very long time with Russell, Rubinstein, and McCormick. It is very important to understand the pathophysiology of these lesions. First, understanding the normal anatomy when you have arteries, capillaries, and veins, and when you consider that in the brain AVMs we don't have capillaries, it's very easy to understand the clinical consequences of that, because we have arteries connected directly to the veins, and every one of you knows that these dangerous connections can be finish ends in hemorrhage, bleeding in the brain, and also the absence of capillary networks consequences may have some ischemia to the brain, and of course is also seizures. So it's very natural to understand that the most clinical presentation of this kind of lesions is hemorrhage, any kind of hemorrhage, intercerebral, subarachnoid hemorrhage, interventricular, subdural hematomas, seizures, and also because of the ischemia and the stealing of cerebral flow, we can have some progressive neurological deficit. And when you have a large nidus, you can have some mass effect, headaches, and also hydrocephalus. It is very important to understand the natural history of brain arteriovenous malformation, because only when you understand that, if you have some good indications for treatment or not. This is a beautiful systematic review, include all studies that analyze the natural history. And then when you see here in the first year risk of hemorrhage, you see that it ranges from 2.9 for unruptured AVMs reaching up to 7.8 for rupture AVM. So the natural history of rupture brain AVMs is worse than the unruptured one. It's very, very well known. And then when we analyze the cumulative 5 years hemorrhage risk, you see that for unruptured AVM, it's less than it was before, at 1.3. But for the rupture AVMs, the 5-year hemorrhage risk may reach 26.5. So the natural history is not so good as some of try to convince us. And for the mean risk for the whole series that was included in this analysis, you can find ranging from 2 up to 4 per year in a cumulative risk. This is a landmark paper analyzing natural history from Finland. I like this paper because they have the longest follow-up, of 24-year follow-up. And then one of the data that came from this paper is that after 24-year follow-up, 23% of the series were dead from AVM hemorrhage. So the bleeding from AVM any time during the whole history of the patient can be deadly for those patients. So the natural history when an AVM rupture is very, very bad. So following the first finished paper, another paper coming from the same group brought the data showing that the risk was highest during the first years and after the diagnosis. But if you have a patient with followed by 5 years and never ruptured, after 5 years, they trend to decreasing thereafter. Also, it's important to recognize some risk factor for bleeding. Of course, prior hemorrhage is the strongest one, deep location. Some papers talk about increased age, large AVM, infratemporal location, gender, but the strongest is the prior hemorrhage deep location. Other factors related to angioarchitectural features is the exclusively deep draining, single draining vein, and also the presence of aneurysm related to the nidus can turn an AVM with a right risk for hemorrhage. So it's important to understand the natural risk history, and then we faced a patient with AVM. We have to have a radiological assessment. Most of the people who bled brings a CT like this to you, and you have some sign of bleeding, but also you can find signals of vessels which strongly suggest a presence of AVM. But the best examination to analyze the relation of the lesion with the brain is the MRI, where you can see the relationship between the nidus in the brain. And you have to have some angiography, especially the gold standard is DSA, digital subtraction angiography, where you can see the feeders that goes to the nidus. Nidus is the core of the AVM, and also the drainage veins that drain this. So it's very important to have at least those two, MRI and angiography, to analyze it, and then you go to decision-making process. MRI can bring you some beautiful images. Also DTI, it's a good tool to help you to see from where the tracks, the fibers were displaced. When I was in the residence training, my dear mentor, Professor Braga, used to say that if an AVM is in the motor area, the motor area was not there. So the DTI tertograph now shows beautiful what we have learned 25 years ago. You see in this example, both motor and sensor. Somebody should turn off the microphone. So
Dr. Hua, please, can you shut down your microphone?
Okay, so you see here in this example, both in pink, the motor strip, in green, the sensitive strip displaced to the posterior aspect of the AVM. Here you can see the motor area in the front, the sensitive area in the posterior aspect. So this is important information when you decide to operate an AVM. And also when you have an AVM located close or over the speech area, you may have some benefits from functional MRI. Going to the grading system for AVM, we have a landmark paper in 1986, a Spencer Martin paper. We have some papers with grade system before that. We have other after that, especially the supplementary classification by Lawton Young, and also the Spencer-Ponce classification is some other classification system not related to surgical, but related to radiosurgery and endovascular. This is our landmark, 1986. Every one of you is very familiar with this classification, Spencer Martin, which takes in account size and venous drainage, eloquent brain, divided the AVMs in 5 grades. And more recently, Spencer and Ponce, the same group from BNI, put the grade 1 and grade 2 and called all together and called it class A. Class B was those grade 3, and the grades 4 and 5 were included in the class C. And more than classified, the BNI group tried to make some general recommendations for those AVMs. So the class A, the main recommendation was resection. The class B, multimodality treatment with preoperative endovascular embolization, surgery for any residual or deep located AVM, radiosurgery. If for the great majority of the class C, the main recommendation was no treatment, but we have to see some exceptions for treatment of class C that include recurrent hemorrhage, progressive neurological deficit, still-related symptoms, and also AVM-related aneurysm. When we have some of those characteristics of the AVM, we have to consider treatment for these patients. So the first question on this scenario is what to do with a patient when you have especially unruptured brain after venous malformation. To do nothing, to make any kind of intervention. So trying to solve this problem, this poor trial called Aruba came to us, and the results of this trial showed that the risk of death and stroke for interventional therapy, any kind of interventional therapy, was 30% against only 10% when you only do a medical management for the patient. So the conclusion of this is that for unruptured brain AVM, you don't have to treat, just to follow it. But when you see the tables, the data that is on this study, you see that the largest number of the cases included on the interventional arm were from low-grade AVMs. Class A, the great majority, almost 70%. So for those kinds of AVM, the main recommendation, we already know, it's surgery. But when you see among the 114 cases, only 5 cases were referred to the surgery, to the microsurgery as a single treatment. So the conclusion, my personal conclusion, anyone who's gonna read this paper have to think about that is that the results of Aruba is not related to the microsurgery. The results of Aruba is related to the bad indication because they recommended embolization, radiosurgery, or the combination of these two techniques. For the great majority of the cases, of course, the results of this kind of policy is bad, is the worst results. So this paper brought to us the reality that we are living in the scenario of brain AVMs. Everywhere you go, you see bad indications for treatment of those kinds of lesions. That's why the results of Aruba and maybe the results of those cases is bad. And again, we cannot consider not to treat AVM as Aruba tried to say, because when you see this paper of Michael Morgan and when you record, when you go back and see the papers from natural history, you see that any time if you have multiple or single hemorrhage at the presentation or after radiosurgery, the morbidity and mortality are very considerable. So we cannot leave the patients just to see the great majority of it. We have to consider those patients, and also the same group analyze that when you do surgery with or without preoperative embolization and compare it with conservative management, you don't have difference with disability and the quality of life in this short-term follow-up. So if you have a treatment that there's no difference with disability, but the mortality from the natural history is considerable, we have always to consider some kind of intervention, especially for those patients with rupture one. And when I say that those patients should be treated, microsurgery should be in the core of the treatment. I learned from Dr. Spetzer that if you are trying if you are intended to treat an AVM, you have to, your goal is the cure. Partial treatment may be worse than leave the lesion alone. But embolization in radiosurgery must be available to treat a patient with brain AVMs along with microsurgery. As I said previously, I'm going to go through some basics because we have medical graduation students, we have residents, we have a young generation neurosurgeon. So the craniotomy should be large because you have to have a normal brain around the whole circumference of the AVM. The dural opening should be carried out carefully because sometimes we have superficial vessels attached to the dura. So it should be very careful when you open the dura. This example, this is the nidus, so it's important to see the normal brain, especially in this case, because here is the motor strip. I can see the anatomy, I can perform a brain mapping, intraoperative monitoring, you have the whole control to the AVM. If you do a small craniotomy, minimally invasive anything, maybe you're having trouble during the surgery. The subarachnoid dissection, it's another step. This example of temporal AVM. So it's a basic principle in the vascular neurosurgery. You have to have the proximal control. So the main feeders of this AVM came from MCA. So you have to open the Sylvian fissure, identify the M1 branch to have the control. And then only after you have the whole Sylvian fissure open, the proximal control, you go and start to dissect the nidus. So it's a very basic principle of the AVM surgery. Try to recognize the venous drainage is very important. I think ICG may help us on that. So it's very important to preserve the main drainage veins until the end of the surgery, until you close all the feeders of those lesions. So it is a very elegant way to try to identify veins. Of course, the anatomy and try to identify the vessels on angiography, as you can see here, the basilar vein of Rosenthal, and see and recognize it in the specimen. So the lab training, anatomy training, the section in the lab, it's a mandatory basic principle for anyone who would like to perform microsurgery. This is a nice illustration from the book from Dr. Lawton that illustrates the types of feeding arteries that you can find in AVM. So you can find the terminal branches that goes direct to the nide, so you can coagulate and cut those arteries. You have another arteries that pass through and doesn't give any branch to the AVM. You have other in transit that give you some branches, but also goes to normal brain. You have some perforating arteries in the deepest part of the AVMs. And then when you have some AVMs that reach the ventricular ependymal part, you can find some choroidal arteries. So this is the most dangerous part of the AVM, and you must to take care of this part of the AVM because these tiny vessels are very tough to coagulate. The next step is the PL dissection. Sometimes the core of the AVM, the nidus, reach the surface. Sometimes it's under the sulcus. So a good tip is to follow the vessels, to follow the vein or arteries to find the nidus. This is a beautiful illustration from Johns Hopkins group showing the circumferential dissection, which is another principle. And also those tiny vessels that came from the deepest part, sometimes you coagulate several times, it do not stop to bleed. And one tip that came also from the book, from Lawton's book, is to first to put a temporary clip and then you coagulate it. So after that, you have a better chance to stop the bleeding. Again, when this reaches the ependymal and the ventricular cavity, you have to go up to the end of the AVM. I would like to share with you some cases. I'm going to start with Class A cases, and then I go pass through Class B and finally Class C case, just to illustrate the way we deal with this kind of lesion. This is a female, 23 years old, presenting only with seizures and rupture AVM, located in the temporal lobe and supramarginal gyrus. Feeders coming from MCA and drainage going into the Labé system. The cerebral flow stealing from the contralateral and also from the posterior circulation. And here is a very important. You see, when you occlude the main drainage vein, what's happening with the nidus start to increase in size. And then when you occlude the last arterial feeder from MCA, now I don't have any other artery feeding the nidus, so I can occlude safely the main drainage vein. So this is a very basic, important principle of the AVM surgery. You never occlude the main drainage vein before you occlude all arterial feeders. In our department, we always perform a post-operative angiography to make sure that we have removed the whole nidus. Another case, female, 20 years old, presenting with headaches, motor deficit. You see a Class A, but you see also some endovascular material right here. It was performed in another department. It was what I called unplanned preoperative embolization. A lot of cases come to us with partially embolization. As you can see here, a small branch come from the ACA go to feed this nidus, and this is the main drainage vein. Here's the angiography. So this is the place where the AVM is. We perform an interhemispheric approach, well illustrating this specimen by Professor Houghton. This is the specimen that we perform. You can see here the both ACAs and the corpus callosum. Here is in the surgery interhemispheric approach. Again, proximal control. So you go before the both ACA, so now we have the control for both ACAs. We have the corpus callosum right here. I'm gonna pass a little bit faster here, just to save time. So now you are in the front of corpus callosum. We perform a small opening in the callosum in order to find that small arterial feeder that was coming from ACA, and then you see that the aspect, yellowish aspect, showed by the previous hemorrhage, saved the branches that goes to the normal brain, and here saving some vein that you can see here. This is a normal vein, so look at the color of the vein. So you can see here part of the nidus right here. So you see here, this is the posterior aspect where the main drainage vein was. Here lateral, more yellowish. So the circumferential dissection. And here, after the dissection of the whole nidus, you can remove the nidus. And because we open the lateral ventricle, anytime we open the lateral ventricle, we like to leave a EVD catheter in order to have a postoperative control of some bleeding, and also from ICP. Pre and post operative angiography show the complete removal of AVM. I like to show this case because it was a male, 32 years old, hemorrhage, stroke. You see AVM located in the mesial temporal aspect over the tent. As you see here, the feeder is coming from PCA, and this is how Dr. Evandro de Oliveira divided the mesial temporal lobe, anterior, medial, posterior. This AVMs was right here in the middle part. I had the privilege to help Dr. Evandro publishing this paper that probably is the best approach for that kind of AVM located that area. When you open the tentorial, you have the whole aspect of mesial temporal lobe, also the ambient system. And if you open the ambient system, like you open the Sylvian fissure, you can reach the middle and also the anterior aspect of mesial temporal lobe. Dr. Evandro liked to do it in the semi-seated position. For me, semi-seated position is uncomfortable, so I decided to operate in this position. And of course, a large craniotomy is useful. You have to expose the whole transverse sinus bilateral, a little bit the occipital lobe, in order to retract the dura and see under the tent. So as you can see here, releasing CSF may help you on this approach. And you see that some adhesions with arachnoid, and also small veins can be sacrificed in order to have space. Look at, even with a prone position, we have a room to go through this approach. Some small veins may be sacrificed. And then you see the tent from inside. Let's keep a little bit here. So you see here the freeboard of the tent, and you already see the branches for PCA. So the other option of approach for that lesion is subtemporal or even transtemporal. So the last thing you see is the proximal control. If you go this way, when you go transtentorial, like you see here, you go directly to the PCA and the branches that are feeding the nidus. So the strategy for the surgery, this approach is perfect for that. So after you coagulate the border of the transverse sinus, you start to open the tent. The other variation that we published along with Dr. Evandro is Dr. Evandro removed the whole tentorium. He resected everything. In this case, I just opened the tentorium up to the free border, and then I kept the tentorium over the cerebellum, so I could protect the cerebellum with the tent, and then at the end, I could reconstruct partially the tentorium. So you see, when you open the tentorium, you reach directly the ambient system, you see PCA, and then we start to see the branches that are going from the PCA to the nidus that is right here. You see? This is PCA, the nidus start right here. So this is the beauty of this approach that leads us direct to the point where we want to be. So this is PCA. I'm trying to identify the branches that are feeding, coagulate them, and cut, as you see. And then you go in a circumferential way. Here I'm in the inferior aspect of the nidus. And then I'll go more lateral. And the nidus ends in the anterior aspect of the temporal horn of the lateral ventricle. So I knew from the beginning that the end of my surgery was the temporal horn of the lateral ventricle. So this is important to understand the anatomy and the landmarks during the surgery. So as you can see here, the PCA completely free. This is the nidus completely dissected. And the last vessel to be occluded is the main drainage vein, which is right here. So after, to make sure that you coagulate it and cut all feeders, you go to the main drainage vein and then remove the whole nidus. This is the angioarchitecture of the nidus. You see here the ependyma of temporal horn of the lateral ventricle, also the choroidal plexus right here. So now I'm sure that the whole AVM was resected, and this is some surgicel in the bed of the AVM. This is the dural reconstruction. This is the nidus, the cranioplasty at the end, and the postoperative angiography showing complete resection. You see that I have showed several class A cases, but every case you have a different feature, different situations. This case, a 37 years old male presented with surgery, large nidus going to the atrium of the ventricle, branches coming from MCA and also PCA. You see here the branches from MCA were already coagulated, cut, the circumferential dissection superficially was performed. And the last part of the nidus, look at the angioarchitecture of the nidus, the last part that cone goes into the ventricle. So this is the part where we must take care to avoid to leave any piece of AVM. Any residual AVM may have bleeding consequences in the postoperative time and for the patient. So we must make sure that we remove everything in every case. So again, in this case, we opened the atrium of the lateral ventricle, so we left EVD to the postoperative monitoring control, postoperative angiography showing a complete resection. This is a nice case, again, unruptured, but partially embolized case. I like to show this case because I had the privilege to operate this case in a live course in Russia, in Tyumen, Siberia, and department led by Professor Sofia Nova. In this course was organized by Professor Sofia Nova along with Professor Borba, and they have a beautiful facility with intraoperative angio CT, as you can see here. So we start with intraoperative angio CT, 30-second acquisition of image. Those images goes directly to the image guidance system. So it was very, very beautiful to have this experience operating this department. So this is the CT scan, intraoperative angio CT, and we performed a combined interhemispheric approach. Look at this in this kind of approach. When you have the dura attached to the veins, you have to leave a piece of the dura attached in order to preserve the veins, and then you make some plastic, dural plastic. But the veins is more important than the dura. Of course, the CSF leak is also important. And we perform an interhemispheric approach along with transsucal approach. In order to remove the embolized part and also the AVM that's still open, and those are images from image guidance. And here you can see after the whole dissection of the nidus, we could remove apparently all the nidus. And because we had that facility, we performed another intraoperative angio CT to make sure that intraoperatively we remove the whole nidus. So we performed another angiography and angio CT, and the angio CT confirmed the complete occlusion. The day after, we performed the DSCA that also was consistent with the previous results. All those AVMs that I have shown to you up to now were low-grade AVMs. This is a nice paper published by CSF group at that time, led by Dr. Lawton. They put all together the series that treated low-grade AVMs surgically, the series that treat endovascular using Onyx, and the series that use radiosurgery for low-grade AVMs. And this table summarizes the results. So when you see the morbidity for microsurgery was only 2.2% against 6.2 for endovascular, 6.5 for radiosurgery, 3 times more risk for endovascular and radiosurgery using as a single technique. The risk of mortality with microsurgery for low-grade brain AVMs was 0.3% for microsurgery and 5 times larger in endovascular cases and 4 times more in radiosurgery. On the other hand, for the cure rate, we had 98.5% for microsurgery versus only less than 30% for endovascular and 75% for radiosurgery. So there was a huge difference between the goal of the surgery of the treatment that is the cure. And more than that, the risk of hemorrhage after microsurgical treatment was only 0.3% against 8 times more endovascular, 7 times more for radial surgery. So based on that, there is no reason to treat or to recommend any low-grade AVM other than microsurgery. Going to the class B cases, this is a large nidus frontal, male, 32 years old, presenting with seizures, DTI preoperative to see the displacement of the fibers. On this case, we had some intranidal aneurysms. This was that case with deep venous drainage by the basilar vein of Rosenthal, contralateral stealing. And for cases like that, in most of the cases, we recommend preoperative embolization like we did here. The surgery seems to be easier regarding the bleeding, but still having bleeding for the deepest part of the AVM, because the endovascular preoperative and embolization cannot occlude all those tiny small vessels that come from the deepest part. So we still have some bleeding from that part. So in this case, we dissect everything, look at those small tiny vessels still coming open from the deepest part. So this is a frontal basal, this is a Fox interhemispheric approach. So after the whole dissection, the last vessel is this vein that is going to the superior sagittal sinus. So now we can occlude it, close and cut after coagulation safely. This is some aneurysms inside the nidus, partially thrombosed. Postoperative angiography showing a completely occluded AVMs. This is the patient at the day of discharge. He preferred to shave everything. We do not do that, but it was a preference of the patient. Another class B case, that lady came, 16 years old lady came to us present with seizures, with 3 embolization, previous embolization. For every embolization she did, she gets some hemiparesis, because the nidus of the AVMs was very close or over the motor strip, as you can see here. And after the third embolization, she had intracerebral hematoma, and she became hemiplegic. So she came to us at this way. We performed some DTI to see that the fibers were displaced to the posterior aspect of the nidus. Here you can see the AVM, the angiography showing branches coming from MCA and also ACA. It was a single drainage vein going to the superior sagittal sinus in this case. So this was that case that I showed previous to you, where we have to have control of the motor strip. Here you can see the part that was embolized. For me, this kind of embolization is not helpful for the surgery. In this case, it was tough because it became very hard to dissect, very close to the motor strip. We performed intraoperative monitoring mapping in this case, and after the dissection of the nidus, here's the main drainage vein, here is the motor strip, the part which was embolized. That was for every embolization she did, she gets some neurological death, because the motor area was being embolized. So this is the nidus after the dissection. This is the bed, and this is the postoperative angiography. I had the opportunity to see the patient 6 months after. She still has some hemiparesis. She is improving after physiotherapy, but she could return to the university and to the almost normal life. This paper from Australia, from the Michael Morgan group, has shown that even for class B or class C, the preoperative embolization does not reduce adverse outcomes. And the whole of embolization, the preoperative management of complex brain AVM by surgery deserve further study. So I agree with that for some specific cases like this that I'd like to share with you. It's a female, 26 years old, seizures. Look at the huge nidus branches coming from MCA, from ACA, and also a large lenticular striate artery going to the deepest part of the AVM. So we discussed with our endovascular team in order to try to embolize that part, which is the deepest part, but they couldn't catheterize that small vessel here. So they proposed to embolize here or here. So I said to them that those parts of the AVM I could reach in the very early stage of the surgery, that embolization for that part could not be so helpful in the surgery. So we decided in this case, go direct to the surgery again with a large craniotomy. You see here with this craniotomy, I can go interhemispheric, I can go subfrontal, I can go transuvin. So you see here the inner table of the flap, the bone flap. You see some impressions of the vessel showing the congenital nature of this kind of lesions. Again, take care when you open the dura because some superficial vessels can be attached. You see here both branches for MCA right here at the very beginning, at the very early stage of the surgery. And now I'm going interhemispherically. And you see here, I just put a clip on the ACA just before it enter in the nidus. And here is the main drainage. So I didn't start to dissect the nidus, and I have control in the both branches of MCA. I have control of the branch for ACA, and I have control of the venous drainage. The only thing that I don't have at this stage is the branches that come from the deepest part. So embolization in that area could be very helpful, but unfortunately it couldn't be performed. So again, it's all about the same. You have to identify the vessels that are going to the nidus, to identify those that are going to the normal brain. I'm going to skip here because of the time. You see, in this case, you have the whole control of the nidus, the sect, but at the end, that tiny vessels that came from the deepest part, they start to bleed, and I spend a lot of time trying to stop that bleeding. But fortunately, at the end, we had a postoperative angiographer showing a complete occlusion. Maybe in this case, the patient had the breakthrough syndrome. We can discuss about that at the end of the presentation. Here is the patient at the day of the discharge. Going to the last part of this presentation, there are some series showing the results for high-grade brain arteriovenous malformation, class C, and the mortality is very considerable for those events. But there are some cases that we should consider treatment. I'd like to show one of those cases, female, 32 years old, presenting with seizures. And here is the point. She was having the progressive left hemiparesis, and she also had a previous surgery for a hematoma evacuation. And after that, in another department, and after that, they couldn't remove the AVM. They put a lot of metallic clip in the vessels, and they recommended perform a radiosurgery. So the patient came to us 5 years after radiosurgery. We couldn't perform an MRI because of those metallic clips, but we could perform an angio-CT. It's a large, huge nidus with several clips inside. Part of the nidus reached the atrium of the ventricle. And here is the angiography showing branches coming from the MCA. Also, a single venous drain going to the superior sagittal sign. Look at this, branches coming from the meningeal arteries through the dura. So the first step of the treatment of the surgery was enlarge the craniotomy, because the craniotomy that they performed for the hematoma evacuation was small. So because it was a reoperation, you can see how attached the dura is over the surface of the brain. But you should keep control and patience in order to keep everything clear, like you see here. So here you can see the main drainage vein. So it's important to try to identify the vessels that you see in the angiography in the surface of the AVM. So this vessel right here is this here. So this is a superficial branches coming from MCA. So we start coagulating those superficial vessels, and then you go deeper and deeper in order to try to find that frontier between the nidus and the normal brain, because that is a ruptured AVM. There are some consequences from the previous bleeding. So sometimes you have some areas you have some plan that makes the dissection easier. Also, after radio surgery, as this patient had, maybe it's easier to dissect the nidus when you have AVMs after radio surgery. So here is the branch from MCA. I will keep this branching open until the end of the surgery, because if you occlude all the superficial vessels, the whole flow goes through the deepest part. So this is not good. So part of the nidus is reaching the cavity of the atrium of the ventricle. Here you can see the ependymon, the beautiful image from the ependymon, nidus inside the ependymon. You go back and forth, you go deeper, and you go back to the surface in another aspect of the AVM. Now I'm using some cotton to separate the normal brain from the nidus, going under the nidus, taking care of this main drainage vein, dissecting some arachnoid scars from the bleeding. And you see here the deepest part of the AVM, choroidal branches, going to the deepest part of the AVM. It's a beautiful angioarchitecture of these kind of lesions. Now I'll go in the frontal part, anterior part of the branch. You see here, part of the nidus. It's very important to have a bipolar, non-stick bipolar. You see here the choroidal plexus. There was a small, tiny vessel coming from the choroidal plexus going to the deepest parts of the nidus, also coagulated and cut. And after you occluded the whole deep vessels, deep arteries, now I decided to occlude the MCA branch. And then after you occlude all vessels, all arteries, now we can occlude the main drainage vein. And after you occlude the main drainage vein, you can remove this huge nidus as a single piece. When you create a strategy in your mind, and then you go step by step, this kind of suture can be very pleasant, like you see in this video. This is the aspect of the nidus. And this is the post-operative angiography showing completely resected of these AVM. Look at, this is the nidus, more than 6 centimeters after so many coagulations. So it's a large nidus. There's no a clear indication for radiosurgery in cases like that. As I told you before, some of these patients may have in the postoperative, even intraoperatively in the postoperative time, the normal perfusion pressure breakthrough. It was published by Dr. Spetzer, which looks great with these yellow jerseys. And also in the postoperative time, we have to be careful in the ICU with the blood pressure. This paper recommends to keep it under 70 millimeters of mercury, and also to take care of cerebral perfusion pressure higher than 50. So the postoperative care and for AVM patients, it's very, very important. When you have some bleeding in the postoperative time, the main reason may be residual nidus. So we have to take care of the deepest part of those AVMs. And I'd like to finish showing you the systematic review and meta-analysis that was published in JAMA, which is not a neurosurgical journal, nor even an endovascular journal. They analyzed all studies related to the treatment of brain arteriovenous malformation, and the overall case fatality was 1, 0.5, 0.9, no difference. Intracranial hemorrhage, on the other hand, was 0.18 for microsurgery, 10 times more for stereotactic radiosurgery, 10 times more after embolization. So the risk of intracranial hemorrhage after the treatment with microsurgery is safer, as this paper published. The complication was 7, 5, 6, no difference between the three techniques. But here is the point. The chance of cure of AVM was 96% for patients treated using only microsurgery, versus only 38% for stereotactic radiosurgery, only 13% after embolization. So when you decide to treat a patient with brain AVM, the microsurgery must be in the core of the treatment. At the beginning of this week, Dr. Jacques Mark talked beautifully about cavernous malformation, and we discussed about propranolol for cavernous malformation. I looked for propranolol for AVM. I couldn't find nothing about brain AVM, but I could find one paper for peripheral AVM in the leg in this case. Maybe in the future you can find something for brain AVM. This is the beautiful Santa Casa de São Paulo building in 1875, I believe. It looks like a Hogwarts castle, as you see. As you see here, the same building nowadays, and every one of you is most welcome to visit us anytime. I'm sure that our chairman, Professor Vega, will be very happy to have any one of you anytime also. And this is my my new home. It is a Camargo Cancer Center, which is the largest private cancer center in the country. Again, I'd like to thank you very much, the Brazilian Society, for this great opportunity. And I'll be very happy to discuss and to answer questions. Thank you very much.
Thank you, Jean. Thank you for this amazing lecture. So now is, in my place, it's 6:04, but in São Paulo, in Brasilia, it's 7:05. We have over 30 great professors and great people interested in vascular surgery between our panelists. So I first would like to open the discussion to our panelists. I don't know if Professor Braga is still with us. If he is, I would like to hear him, because as Professor Jean said, he was the one that introduced us to vascular surgery. and he was always very, very enthusiastic, especially with AVMs. Is Professor here, Professor Braga?
Yes, yes, I can
Can
see
you
him.
hear me?
Oh,
Yes,
sir.
sir.
Can you hear me?
Yes, sir.
Yes, sir.
Can you hear? Can you hear me?
Yes, sir.
Are you hearing me?
Yes, sir.
You are only laughing. Can you hear me?
Yes, sir.
Yes. Very nice, Jean. I liked it very much. Your exposure. I knew Dr. Jean about 25 years ago in Belém. He came to our department to spend 1 year as observer. And then he started residency. He, Paulo Cadre, and Paulo Porto was 3 of my last residents. And since then, I am very proud about the degrees that they are scaling, improving, became one of the best neurosurgeons of our country. Not the best, but some. I'm very proud of you. I think
Thank you.
you have
Thank you,
reached.
sir.
I have no question because I didn't see any improvement in these last 15 years. The thing I used to do, and now only the technique is better material. But I think the same questions. We had a nice experience of AVMs, of eloquent areas. I was looking at the book that we wrote. You know this, you still wrote some chapters. And the questions are just the same. I ask, is there any good improvement about the endovascular and the radiosurgery helping the surgery of AVMs?
I believe yes, sir. First of all, it's an honor to have you as panelists in this presentation. It's always nice to have you around. Thank you. And I think yes, the endovascular techniques is improving in any kind of lesions, aneurysms, and also AVMs. They can reach different parts of the nidus. Nowadays, they are doing venous embolization, which is in our understanding of this lesion, it's a little bit dangerous, but they are showing some results that may be promising in the future. Also, radiosurgery is showing important results for those cases that at the very beginning were considered as untreatable. So for those cases, we can perform radiosurgery. And sometimes the preoperative radiosurgery can help you in the microsurgery because it makes this dissection easier. So there are some combinations among those techniques, microsurgery, endovascular, and radiosurgery, that made the treatment for these kind of lesions better nowadays.
Okay, let's take over here. We are now 7:11. We have a lot of people who want to say something. Let's start here with Dr. Marcos. Dr. Marcos is here.
I'm here.
Yeah. Can you say? I'll make one question for the panel, for Dr. Jean and for the whole panel. Dr. Español is around?
No, I here.
Okay.
I don't have video.
I saw one presentation about the patient with AVM rupture and a big hematoma. Okay? It is a large AVM. You remove and make for each of one remove the hematoma and the AVM, or remove the hematoma and leave the AVM to see how to organize again to take the AVM out? Dr. Marcus.
If it's a large AVM, I would leave it alone. I would take the hematoma and come back when I have time to study the angiogram and the brain is relaxed. You'll get much better outcomes that way.
Dr. Umura?
Yes, the same. It depends of the grade of the AVM, of course. What I do is try to do the most that I can. For example, if the patient had a aneurysm related, I try to clip and prepare the patient for the actual surgery of the AVM. But if the AVM is not so big, I go for the AVM always.
Professor Colley.
But Borba, you were asking
Okay.
without a previous angiography?
No, they did angiography. They know they have an AVM. They bleed and have a big hematoma. A large hematoma, not a big, large hematoma. So Dr. Colley have problem with connection. Amir.
Okay.
Oh, Dr. Colley, okay.
For this case, Dr. Borba, I think that if the AVM is small, after draining the hematoma, you can operate the AVM. But big AVMs, I think that's not a good wise to do during the operation of the hematoma. I prefer to wait, drain the hematoma and waiting for a posterior removal of the AVM. I'd like to ask you one question for Dr. Jean, a general question and another for all the panelists. My question for Dr. Jean is, what do you think that general neurosurgeon should do or should know about AVM, and what he should do with AVM? And the question for all panelists is, I have no experience in operation after radiosurgery. Dr. Jean said that radiosurgery become easy to operate. What do you think?
First of all, I'd like to answer the Borba's question. When you have a bleeding from AVM, most of those patients goes to the ER, and they are considered hemorrhage from. There are some noise from hypertension. So most of those patients have only CT scans. They don't have angiography, the ER. They don't have MRI for the most patients. So it's very difficult to decide to go to the surgery to operate the AVM when you don't have MRI and angiography and the whole spectrum of the radiological exam that you can have. So I agree with Jacques that you have to have the preoperative assessment, the best way to decide it. Answer Professor Colley. Professor Colley, when I was resident, I was seeing Professor Braga operating. I never operated at that time any AVM. And then I start to read about, I start to see him operate, I start to see some videos from Professor Yassagil, and then we start to go to the lab. I think it's a long way to run up to you feel comfortable to start to operate an AVM, and when you feel comfortable, you have to start. I believe that you have to start with low-grade AVMs, small AVMs, superficial AVMs, and if you have such opportunity like I had, having mentors by your side during the surgery, I think this is the best scenario. But I strongly believe that AVMs, like aneurysms, like any other neurosurgical disease, even the young generation should not be prepared, but to start to be prepared in some point of your career. So I think nowadays we have a lot of labs to train, to practice video. The information is available for everyone. So I think that we have to do that, because it's the only way to keep the microsurgery on the top as we have to be. And sometimes we say to the young generation that some kind of lesion is very tough, very difficult to operate, and they refuse to operate in the whole life in neurosurgery, because they heard at the early beginning that they could never operate that kind of lesion. I think we have to stimulate the young generation to prepare yourself to deal with this kind of lesion. I'd like to hear from Jack if he has some experience with surgery after radiosurgery.
Yes, definitely. It makes it actually quite easy. I have several cases. I remember the most recent, I did contralateral interhemispheric. It's like removing a tumor. Now, of course, it still was bloody, but also I'm sure all of us have the same experience. An angiogram may look that the AVM is completely gone after radiosurgery, and you go in to remove it and it still bleeds. So false negative angiogram following radiosurgery I've seen a couple of times as well. Patient presenting with hematoma after radiosurgery with no nidus visible on angiogram.
Dr. Spagnolo.
I have a few cases of surgery after radiosurgery. And the difficulty I had in those patients was in small fields of the AVM, it was not easy to recognize it from normal and pathological fields. It was just few cases after radiosurgery. I don't know if it was for the radiosurgery. The other question about the hematoma with large hematoma with AVM, I have a serious patient. In those cases, patients, I just did the compressive craniotomy, and I didn't touch the hematoma. I wait after the patient became improved the neurological condition, and I performed the surgery in better conditions. I think it's better because the brain in emergency, bad clinical conditions is not good for a surgery. And for that, I prefer to perform the compressive and to wait.
Dr. Tatajiba, want to say something?
So this is a very interesting question. And if we recall the cases we have had, in the majority of the cases, we did a partial removal of the hematoma just to keep the patient survived without removal of the AVM on this acute situation. The exception was if the hematoma appeared following embolization of the AVM. So in case that we have seen a couple of such cases as well, as complication of the embolization, the hematoma produced by the congestion of the veins. In this case, we enter to remove the hematoma and to remove the AVM. That means it depends on the situation. I cannot say we did only this kind of procedure. Yeah. But in the majority of the cases, we did the partial removal of the hematoma, if it was a spontaneous bleeding.
Dr. Amir?
Yes.
Large hematoma. You remove and continue bleeding. What do you do now?
Okay, that's the difference. That's what I was saying. So I'm in line with what most people said, including what Jacques and Marcos mentioned. Now, if it's a very small AVM, grade 1 and 2, and you understand the anatomy, if you have a pre-op angio from before, a very good CTA, then for that, I might go for a resection. Now, if you are dealing with a grade, let's say complex grade 3 or a grade 4 AVM, which has bled, and you just go for removal of the hematoma and the AVM continue to bleed, I think there should be a way to get a hemostasis and don't go after the resection. So if I can easily get an hemostasis, which has happened in the exact scenario that you are mentioning, I would try to get the hemostasis done, get the blood pressure low, and come back later for a complex AVM once I have a better understanding of the situation, specifically if we don't have an angiogram. If you cannot get a hemostasis, you work until you get the hemostasis, which it should be possible.
Dr. Mateo. Mateo's here?
Yes. Hey, Mateo.
Oh,
I don't hear. I don't hear.
turn on your microphone. Okay, go ahead. And who else want to say something? Dr. Pablo Ángel. Pablo Peredo, Pablo
Sí,
Ángel.
hola. ¿Me escuchan?
Sí, sí.
Do you hear me?
Yes, yes.
Well, I want to congratulate. I saw him operating in Russia, and I know he's a wonderful neurosurgeon. So I don't have too much to say. I learned in this presentation. So thanks, Jean. You're
Thank
great.
you, Pablito. It's very good to have friends around.
Okay. Let's have some.
Luis, can I make a comment? Or
Yes, yes, yes. Go ahead. Everybody can talk.
Jean, hey, Jean, the supracerebellar transtentorial approach for a medial temporal lobe AVM, I think we have to, a beautiful surgery. All of your videos were fantastic. You have to warn the young people probably not to do it if there is an anterior choroidal feeder along with the PCA, the middle temporal trunk of the PCA. It'll be very hard to get deep proximal control at the depth of that view. Don't you agree?
Yes, I agree with you. I think this the first time I did it by myself, I have seen a lot of surgery from Dr. De Oliveira, the Professor Evandro, and then I went to the lab and practice every course that I helped Bob around the world. I took some specimens and tried to simulate the surgery, and then after that I try to start with this approach because it's not a daily approach. In fact, it's a new approach for this area if we consider all the available approach in the neurosurgery. So it's not for the beginning. We have to practice in the lab.
May I make a comment? I have a question and a comment for Jean. One about that AVM that you showed with the lenticular striate feeders that you wanted to be embolized. I'm very much in favor of preoperative embolization with onyx, not for grade 1 and 2, but for anything after that. And sometimes, even if they cannot, or we cannot get to that pedicle, the onyx can, you can't always predict, but you can get into the nidus from MCA or ACA feeders, and the injection of onyx will get to the area of that lenticular striate. So I think this is something to consider, even if that specific pedicle cannot be embolized, but it can be reached through the bigger pedicles because onyx can fly inside the nidus. So that's a possibility.
I agree with you. I think it depends of the experience of the endovascular team. So we try to convince them to try to embolize that. They believe that they couldn't do that. That's why we didn't do. they, as I said, they proposed to embolize the superficial areas. So we have to remember that for every preoperative embolization, we have a risk for rupture and bleeding. So we must consider that anytime we recommend embolization. So because we consider that those superficial parts of the AVM we could access in the early stage of the surgery, we decided not to embolize that part. But of course, if I could embolize the deepest part, I would recommend.
What about a thulium laser? Have you have any experience with that, or if anyone in the among panelists have any experience with laser for dealing with deep perforators around the AVM nidus?
I think nobody. Dr. Pereira, Pablo Pereira, Uruguay.
Thank you very much. There's a beautiful presentation, Jean, as usual.
Thank you.
And we enjoy a lot. I have two questions. The first of all is, what about your timing between diagnosis and surgery? And the most important part is, what is the timing between a bleeding, an AVM which bleeds, and the surgery? And also, the second question is, if you have an AVM, a grade 3, the big one or the deep one, and you think it will be a breakthrough syndrome, don't you prefer to have steps and step embolization previous to the surgery? And this is another question. If you do an embolization prior to the surgery, which is the timing between the embolization and the surgery? Thank you very much.
Yeah, you have this question a lot in the chat. Go ahead, Jean. Dr. Vega, want to say something before Jean? Or?
Yes. Hi. Are you here?
Yes.
Yes. Okay. Thank you. First of all, congratulations, Jean, for your presentation. Very clear, informative, as usual. Very illustrative and challenges case. Thank you for showing us our beautiful building at Santa Casa in a Gothic style. Thank you. Regarding the question of Borba, hematoma in the AVM, I removed the hematoma in the emergency situation. I think the clinical conditions, neurological exam of the patient is not so good. So I removed the hematoma, did hemostasis, and did a discompressive craniotomy. So I think it's difficult to deal with this angry brain. In next opportunity with angiography and the others recursions, I will try again to remove the AVM.
I'm back.
My first question to Jean is about postoperative deterioration. In some cases, do breakthrough, causing swelling and eventually hemorrhage. Have you ever had this complication? And how do you think this happens?
Yeah, it's the breakthrough. There are some neurosurgeons that do not believe on that. There are others that believe. I am in the second group, I believe, because I had it twice, and I couldn't explain with any other pathophysiology than breakthrough. I think this happens only on large nidus, and I think the most important thing is the postoperative time for that patient. At the end of the surgery, you go through the OR to the CT scan, perform a CT scan if everything is okay, keep the patient sleeping 24, 48 hours, and then another, of course, monitoring the ICP. And then we start to wake up the patient after a normal CT scan. I think this is the way I deal with larger AVMs. I try to keep the patient sleeping at least 24 hours, 48 hours. But if you have some bleeding, I think you have to go directly to the, of course, if it is a large volume of bleeding, you have to go to the OR again. If it's a small bleeding, I think you have to perform angiography to see if the main reason to have a postoperative bleeding, it's a residual nidus. So you have to look for a residual nidus.
I see Dr. Natal here have a large experience in AVM. Okay. After you go to Guilherme in, okay?
Okay, thank you.
Natal, go ahead, please.
Thank you. I would like to ask you, Jean, because we talk about the basic technique for resection of AVMs, but for me, the main problem in the AVMs are the deep perforators and the reactivity around the nidus in big AVMs. So I never go into operation if I don't see a compact nidus. If you see what we call very, very scarce vessels around the AVM, you can anticipate, or you may anticipate a severe bleeding. How do you deal with this severe bleeding when it appears during surgery? Because for me, it's the main problem in the AVM surgery in general.
I think the surgery, AVM surgery ends when you remove the whole nidus and then we stop the bleeding. You can, I know that sometimes it's very tough. That case that I've shown to you, that I didn't perform the preoperative embolization, I spent around 6 hours to remove the nidus, and then I spent more 6 hours trying to stop the bleeding from the deepest part. After the whole nidus was removed. So it's very difficult. It's very difficult to keep the patient, for you in the surgery, attention, because you are tired during the surgery. You have to concentrate your mind on that. But I had this on 2 cases, and I kept on the field up to the end. You cannot leave it bleeding. You only can leave after you stop the bleeding. You have to control the bleeding.
I would like to share my experience with this kind of bleeding. Yeah.
Please.
At the beginning, when you face a severe bleeding, we ask the neuroanesthesiologist to lower the blood pressure, as you mentioned before. If this is enough to control the deep perforators, then you coagulate, you close it, and you finish the bleeding. But in some cases, this doesn't function. So you have to go. So another thing that we use is to lower the energy of the bipolar forceps, because sometimes these tiny vessels become adherent to the tips of the coagulator and bleed again because there are ruptures. But in many cases, even when you do all these things, the bleeding continues. And as you say, you cannot go out with a surgical bed bleeding, because you know what that means in the post-operative period. So in some cases, I have used a gauze in the nidus and trying to stop the bleeding. And in some cases, it functions. This is what?
Using what?
Gauze, tissue, textile.
Okay.
And then, you put inside, you wait, because you have to wait, aspirating until the bleed stops. The patient goes into the ICU with a low pressure. Exactly. And sometimes you have also lost many fibrin, blood vessels. They're not blood vessels, red cells, And so this is a very desperate condition. So we wait for 3 or 4 days at the ICU with the patient stable, and then go again to the surgical room to take out this material and continue the surgery after the blood elements are again in good levels. I don't know if somebody in the panel have some experience and some comments about it.
I saw that Dr. Eduardo Vieira just turned on the camera. Want to say something, Eduardo, and Dr. Jorge Mura? Before Dr. Go ahead. Dr. Jacques Marcos, you want to show one case. Dr. Guilherme want to talk, say, Guilherme Cabral, go ahead.
Can you hear me?
Okay, but very short, okay? Let's go direct to the point. Okay, let's go direct to the point. Okay.
Congratulations, Jean. I have 2 questions. For the follow-up, long-term follow-up, everybody knows we have 2 kinds of AVM nidus, regular nidus and diffuse nidus. And do you sometimes you have a surprise in long-term follow-up in microsurgery removing AVMs or radiosurgery AVMs? Do you consider a cured patient after the first and the second after 1 year angiography? And how long do you follow up your patients with cured surgical AVMs?
Yeah, thank you for the question, Giga. For the most of the patients, I do postoperative angiography in the postoperative, the immediate postoperative. The patient doesn't leave the hospital before a postoperative angiography, so they go home knowing that there is no residual bleeding in the post. Of course, every time you can do that. There are some hospitals in the public health system you cannot do that, but in the private I do for every case. So I consider the postoperative angiography, it doesn't appear enough, it's secured, but of course I recommend to the patients perform angio-CT every single year thereafter.
I think in children is different. In children, you need to repeat the angiography. It's different than in adult patients.
Yes.
With children, unfortunately, sometimes you have a normal angiography, and you can have a reappearance of the AVM. In that cases, we do a angiography at 6 months, 1 year, and after that we follow the patient in order to rule out regrow of the AVM.
There is one question from the chat here that is coming, more than one. If the association between aneurysm and AVM will change your strategy. Who want to take it? Who want to take this question? Go ahead.
Sorry, what kind of aneurysm?
I don't know. I have no idea. I said about aneurysm and AVM.
Okay.
That's it. We have 3 types of AVMs: the pre-nidus.
Okay, and Dr. Marcos, Jack, you're still here? Okay,
I'm here.
Can you share your screen to show your case?
Yes, I thought this is interesting for the panelists. I will do it right now.
Please share your screen.
I will do that. Do you see the slide?
Yeah.
Yes.
Okay, well, I know we're short on time. Very quickly, this is a patient that was enrolled in Aruba when he lived in New York, not at our center, and was followed, and then he bled. So he had homonymous hemianopsia. He was obviously in the conservative arm, and look at his CT scan. I'm showing this case for 2 reasons. Now I'm going to show you angiograms. Here is the right external carotid. You see that? Okay. This is right external carotid. Next is right internal carotid. This is right vertebral. I'm going fast just because of time, and probably the details are not terribly important, but I will ask the panelists in a second, what do they call this lesion? Is it an AVM? Is it something else? And you know, what they would do about it. Left external carotid. And left occipital artery injection. Left internal carotid. And here is the MRI. So maybe I don't want to go through the entire case, but Jean, I don't know if you had chance to see, Jean, what I was showing. What do you think? What would you call this? And then what would you do about it?
Okay, you're back.
My connection is not so good, but I could see the case. Yeah.
Yeah. Look.
Are you hear me?
Yes, I can hear you.
Yeah. It looks like a AVM. It's a high flow. There is some large aneurysm related to the nidus. I could see the whole angiography.
Yeah, Jean, sorry to interrupt you. What do you make of all the external supply? Look how much external supply there is from external carotid, from, you know, occipital, transosseous, quite dramatic. So
we have two guys here from the chat, Dr. José Alberto and Guilherme. Now they say that dural PO fistula.
So yeah, so what I'm really asking, should we call this a PL AVM, or should we simply call it dural AV fistula, huge one, with parasitization from the PIA? That's really the opinion I'm looking for. What do you guys think?
I think that is a dural PO fistula, not AVM.
Dr. Ahmed from Bangladesh, I think so. He said that proliferative angiopathy.
I don't think so. I don't think so. I don't think so.
Okay.
It looks like a fistula, dural fistula.
Yeah, it's, but there are some PO also. Feeders.
Okay, you don't have so many time. How you treat this? Did you treat already, Jack? Oh.
I did, and I'm not going to show you this. It takes too long.
You did endovascular or you open?
Both. Several sessions of embolization. You can imagine huge transosseous flow, and then I excised it. This was a fistula that was mislabeled for many years as AVM, and I'm showing it because look, if you look at the MRI here, it's very difficult. I showed this to an endovascular panel in the Middle East with Moret and others. 50% called it an AVM, 50% called it fistula. But you see, it's really mostly fistulous vessels. The only thing you might call an AVM, I don't know if you can see my pointer, the nidus, I mean, is here. The rest is just big pipes. Unless somebody disagrees, but this is what it turned out to be. So it's not always so easy to diagnose an AVM versus a large fistula. That's my point.
Great.
I'll stop sharing my screen to allow other people to speak.
There is one question here, or a lot of questions from the chat saying, every AVM need preoperative embolization, yes or no?
No.
When you decide to do preoperative embolization?
No.
Only for large AVMs. And when you decide to do that, mostly of the cases we perform 2 or 3 steps embolization for large nidus.
Who wanna say different? Who wanna? Dr. Fausto Ferraz is quiet here. We embolize everyone? I know you like embolization.
Hi. Nice talk, Dr. Jean. I do not embolize every single lesion, just when it's asked by the surgeon. In my opinion, the whole of embolization should be the deepest feeders in order to help the surgeon for the difficult parts of the AVM. And what I believe we need from the endovascular point, it's to really understand the disease, which is the most complex in our field, because, you know, we have many places in Brazil where we don't have such skilled surgeons to do that kind of surgery. And we may need some kind of embolizations, even only with the only option for the treatment. So mainly for class A, where we can achieve total occlusion, we may follow up from for long term this patient, because we may see some neoangiogenesis that may recur the lesion, but in summary, the endovascular hole for AVM should be preoperative for the class B lesions, and only with skilled hands, total embolization.
Let's go follow this question, okay? Embolization, cure, AVM, is a fact or myth? Dr. Pablo Rubino, are you here?
Yes, I'm here.
What's your opinion? Embolization cure AVM is a fact or a myth? I don't know if you said fato or mito.
Okay,
What's your opinion about that?
I think that the embolization can only cure the AVM that are very easy for surgery. I mean, grade 1 and grade 2. So this is my opinion regarding the cure of the AVM with embolization. I use embolization previous to the surgery. I think that for the deepest part of the AVM, because as a surgeon, the most difficult part of the AVM is the deepest part, especially when you have some perforated branches. So I asked my endovascular to treat this part of the AVM, but I don't think that you can cure the AVM with the endovascular treatment alone, just only in grade 1 maybe, or grade 2, that is very easy for surgery. I cannot see the camera, but I am not allowed to put my video. I don't know why.
Thank you, Pablo. I think that the AVMs that you can cure with endovascular, it's only small AVMs, and the risk that you give in those procedures is very high, the risk of intraoperative bleeding. While when you consider the same AVM for the surgery, the risk is very low, as I said in that meta-analysis by the Lawton's group. So there is no reason to refer those patients for endovascular as a single treatment, because the risk of surgery is very low for low-grade AVM. So yeah, I believe you can cure, but the risk is very high.
Dr. Natal, for small AVM, it's possible to cure with embolization. Why to do surgery?
Turn on your microphone, Natal.
Okay. In my experience, in cases that have been followed for more than 10 years, I have seen cases with recanalization after apparently total disappearance from the angiography after endovascular treatment. So I think, same as Jean, that most of these patients with grade 1 can be operated with a very low risk, and for me is the best option for treatment. Actually, in our hospital, we have a a committee for discussing all the cases of AVM. And at the beginning, small AVMs are sent directly to microsurgery, not for endovascular therapy.
I'll make one question more. Which case you say, see, this case I sent for embolization, no surgery? Nobody? Dr. Apio?
Yes, yes. There are some situations when you decide not to treat the patient's grade C, class C AVMs, and it's considered not treatable or very high risk for treat, and the patient has some targets as intranidal aneurysms that it's a high risk for bleeding, so you can decide to embolize specific targets in the nidus or close to the nidus in order to theoretically decrease the risk of hemorrhage in those cases that you believe you cannot remove everything.
Can I say something about this?
Yes, go ahead.
We're all here, most of us are aggressive microsurgeons, but it has to be said that there have been significant endovascular improvements. I mean, you see what can be done through endovenous embolization. If onyx can occlude the nidus and the vein, those AVMs will not recanalize. Having said that, it does come at high risk. That's why somebody like Jacques Moret does not embolize, does not treat unruptured AVMs, because the complication rates per session are about 12%. But it's certainly not a myth. You go back even to Palafani's papers many years ago, he was curing 40% of AVMs that he selected. Again, because these are, he's a master, he understands angioarchitecture. It's like, I disagree that general neurosurgeons can remove AVMs. We need to be super specialized to do a good job. So I believe this should be said to complete the discussion for the young people to know what might be possible today.
Dr. Apio, go ahead.
Yes, very quick. First of all, I might have misunderstood Dr. Fausto said, and correct me if I'm wrong, but in places where you don't have a well-trained neurosurgeon and you have an endovascular, if you're really sure you're curing the patient, you do. If you don't really curing the patient, you should send them to a best center. And the other point to the whole panel is, which is the patient where you say, we don't operate, we don't send to radiosurgery, we don't embolize, and say the best for the patient is doing nothing?
Yeah.
That's my question.
The Aruba is right.
Class C AVMs, the great majority of Class C AVMs will have to do that, to send the patient home.
And what you say to them?
But we used to see AVM, first session, embolization, second session, embolization, third session, embolization.
I have one case.
Fourth session, embolization, and bleed.
10 sessions.
When to stop?
When did it bleed?
Guilherme, go ahead. When you decide to stop, you do the first session, and you do the second session, say, now it's okay, now you send to radiosurgery, now you send it to surgery, to microsurgery. When you decide this?
It's all about this session, the quantities of sessions. It's about the approach, the feeders. If you have good feeders to go with endovascular, we go with endovascular. If you don't have good feeders to arrive with the good technique, we stop.
Dr. Collier has a lot of experience in AVM, previously embolized. When endovascular guys send the patient to you, when bleed, they cure?
No. I send my patient to the endovascular, not the contrary. In my institution,
when they
the patients come to my outpatient department and we discuss what to do. we never do embolization in grade 3 or C if we don't expect to do some surgery after.
It's perfect. Perfect.
Can I make a comment or a question in the comment that Professor Marcus said? So, Professor Marcus, you point out the results of Professor Balavanis. We used to say that AVMs is not for all neurosurgeons. So my question to all the panelists, but especially to you, is should AVMs not be for all endovascular surgeons? Should we also have endovascular specialized in AVMs, as was Professor Balavanis?
I completely agree with you. Absolutely. I have many of my friends who are duly trained. I'll give an, well, I'm not going to mention name. Some of them decide, some of them said AVM is too complex. These are mostly microsurgeons who decided to retrain in endovascular. So they confess they are not going to be top tier in their specialty, and AVM is a very complex endovascular treatment. And as everybody says, I don't do endovascular, but everybody says, coiling aneurysm is nothing, is simple compared to the thinking and the techniques of AVM embolization. I agree with you completely. It's high tier special skill even within endovascular.
The problem is they only have 4 types of surgeries in endovascular: AVMs, aneurysms, fistulas, and that's it. So if it
they have to do, so every endovascular has to do.
Well, there is a
diagnosis and geography.
Now you got the ischemia.
Yes, now they have ischemia.
Can I give a short comment about it, especially for the young generation? I've seen very often that many cases are sent into the endovascular therapists, especially neurologists and people, neurosurgeons even, without a lot of experience in treating AVMs. But there is a lot of scientific evidence that endovascular therapy could not be considered a terminal treatment as neurosurgery and radiosurgery. Then we should be very careful when we send a patient to the endovascular therapist, because if you catch the message of people with a lot of experience like Jacques Moret, this is not the common state of all the endovascular therapies. So we should be very careful as to consider endovascular treatment as same as effective as radiosurgery or microsurgery.
One important thing is what points out by Jacques Morcos, is that the technology improves a lot in endovascular surgery. In the angiographers, so you can see tiny vessels that 10 years ago you can't see. You have more flexible and useful catheters, and you now have different options of treatment like venous approach or pressure cooking mechanism. So there's a lot of things you can do now that 10 years ago you can't. So I guess the most important thing is you have to think the patient with your team and decided to do what you want, not 1 or 10 sessions of endovascular treatment, but what patients need. And after that, decide if the patient is candidate for surgery or not. But it's important what Professor Colley pointed out also. If you decided to start the treatment of a patient, you have to finish in surgery.
Today
I'd like to do a comment.
We have 90 countries, 90 countries. Congratulations, Dr. Jean. People from Africa, from Asia, from Uzbekistan. What time is Uzbekistan now? Dr. Colley, go ahead. Dr. Colley.
I'd like to do a comment. I think that embolization, really, I agree with Dr. Jack Mork that should do by the senior neuroradiologist that do embolization. In our institution, only the senior neuroradiologists do the embolization. And what we have seen is that as better is the neuroradiologist, less complication, because he can understand very well what he are doing. And I think this is important. The number of sections is not important. What is important is that the procedure can be done safe. This is our position in this matter.
The problem is the definition of safety, and sometimes it's difficult to. There is one question here. The guy say, I don't know, find his name now. A patient with 10 years history of seizure, with diagnosis of AVM, grade A AVM. Should you treat or not? No bleeding.
The seizure is untreatable with medicine.
He didn't say. Okay, it's treated. It's treated.
If you want to treat the epilepsy or you want to treat the AVM, because you have to treat the AVM because it will bleed or it has risk to bleed. But if you want to treat the epilepsy, it's a completely another issue.
But
it's 10 years. It's 10 years. They're the AVM.
If you have a long-term follow-up of this patient, that AVM will bleed in any time. So if you have the possibility, if you consider that it's possible to remove the AVM with low risk of deficit, you should consider for treatment.
But your counsel must be that he stay with the epilepsy. Probably he will keep the epilepsy.
Yes, but the chance of cure the epilepsy is higher if you remove the nidus also.
10 years is a long time. The epileptogenesis of the brain is
at least control. At least control.
There is one question here. The guy say, I saw a lot of illustrations in Dr. Jean's presentation to use micro clips, a lot of micro clips. But I didn't see in his videos why you didn't use these micro clips. Is economical issue or technical issue?
At the beginning of my experience, I used to put clip in every single large vessel that I used to coagulate it. And nowadays I use clip in very hair, but in those small feeders coming from the deepest part, it's a good technique to put a clip, to identify the vessel, to put a clip, coagulate, and then remove the clip. Sometimes also you have to make sure that when you occlude the clip, you don't have consequences in the whole nidus. So I use clip to test some vessel occlusion during the surgery, to perform ICG after occlusion, to see if you have some changes in the hemodynamic of the MRI. Of course, if you are operating in a patient in the public health system, you don't have too many clips to use. But I believe the most of the Brazilian neurosurgeon has his all set of clips to use it temporarily. But I think it's very useful during the surgery.
Dr. Felix Paul just come in. Where are you, Felix?
He just sent me a message saying that
he's here.
You didn't give an opportunity to him to make questions.
I really congratulations. It was a fantastic speech, and I made a question, but you answered the question from other guy about radiation in grade 4 AVMs, big AVMs, grade 4, radiation first and operating after.
It's a feeling, in fact, that we have that probably after radio surgery, we have a better condition to dissect safely the nidus. Unfortunately, our colleagues who perform a radio surgery do not refer those patients for us. It's very rare, this situation. But I believe it could be a strategy for large AVMs that has bled once, twice, and then you have to do something. The patient has multiple hemorrhage. You cannot stay just looking the patient. You have to decide to make anything even for class C AVM. So in this situation, you have to consider any strategy using endovascular, radiosurgery, and microsurgery.
But how long do you wait? How long do you wait before doing the surgery?
You mean after radiation?
After radiation.
Yeah, you have to wait at least 3 years to see the results of the radiation in the nidus. So it's a long-term follow-up, and sometimes during these 3 years, the patient has some hemorrhage during this time. So it's not very safe to wait that, but you have to wait.
We still have 380 people online. Okay, let me make a question for young neurosurgeons. Okay, we are seeing AVN, unruptured AVN, and unruptured aneurysm. Okay, when you talk with the patient, what do you say in AVM and in aneurysm? You say the same thing? You have a bomb in your head, can bleed in 5 minutes, in 10 minutes. What do you say for the patient? Dr. Felix, Paul, you just came in. What's your approach for the patient with unruptured AVM, unruptured aneurysm? Is the same?
No, AVM has a complete different history, a complete different approach, I think. You have to consider a lot of other things that you don't consider when you are dealing with an aneurysm. Aneurysms are much easier to decide and to perform. So I think an aneurysm is straightforward, and an AVM you have to think a lot before indicating any treatment.
Dr. Matteo.
I don't know if I answer your question.
Yeah. Dr. Matteo.
Yes,
How you say
think,
for Argentinian people?
Okay, hello. First of all, very good conference, Jean, as always. I think it's different. In the AVM is more straightforward, in my opinion, because unless grade 4 and 5 of Spetzer or the C grade, the other ones are surgical, in my opinion, unbroken AVM. I still have some regard with some grade 3 of Spretzler. Lawton called him 3+, or are near eloquent area. And in aneurysm, you have to see several things. The age of the patient, the dimension of the aneurysm. I think is more easy not to operate a patient with an aneurysm, incidental aneurysm, than a patient with an AVM. That is more dangerous because you have more possibility to bleed in the span life and with several complications also.
Rabin, as a young and bright Mexican neurosurgeon, you want to do surgery, I'm sure. What do you say to the guys?
Thank you, Professor Borba. First, I would like to congratulations Jan for the masterclass presentation. I learned a lot. And I'm a young neurosurgeon. I learned operate AVMs from Professor Natal. He teach me, and I am want to tell you a comment, because I think the young people only think about the no complicated procedures like radiosurgery and endovascular surgery, but I think we need to learn more and practice and to do sub-specializations about vascular surgery. I think the AVM surgery is the most complex of the neurosurgery. It's the most elegant and complex surgery, but we need to try to invite the young people to learn this kind of surgery, because this is just the only way to cure the patient.
Dr. Natal, Dr. Colley.
My first question to Dr. Jean was what the general surgeon should do in AVM. I think that Dr. Jean was very polite. General surgeon said should do nothing unless to drain the hematoma in case of risk of life. No more than this.
I think young neurosurgeons should have great professors like Professor Colley by their sides to help him to start to learn how to operate those kinds of lesions.
Yes, Jean, I agree with you, but the general neurosurgeon after some age are in condition of training more. This is the big problem. For young neurosurgeon, there is no doubt that they should train very well and do everything.
I agree with you, sir.
About your question, Professor Borba.
We're in trouble here.
About
Dr.
your
Pereira,
question,
go ahead, Dr. Pereira.
About what to say to the patients. I try to explain what I think and the risk I feel between in the approach of the treatment of this patient. And I think if I go with the truth and I explain him the percentage of the risk of bleeding or the risk of become epileptic or what so on, finally we can take the decision together. But I try not to get fear in the patients.
Yeah.
Dr. Mura, want to say something? Are you still here, Jorge?
É o Jorginho Corrêa, do Rio.
Aqui, ó.
Turn on your microphone.
Vou deixar ele falar. Só não fala muito.
My microphone is turned on.
Yeah.
Yes.
Are you listening to me?
Yeah.
Yes.
Well, excellent presentation and some very nice points that we can resume and talk about. The first one is embolization. I think that I saw many cases of 1, 2, 3, 4 sections of embolization, and for me it makes no sense for this. I think that embolization to cure an AVM is very hard deal. Even if it's a grade 1 or grade 2, I think the risk to bleed is the same as grade 3 for endovascular team. So I think that endovascular team in treated AVM must deal together with microsurgical team, and most of the case in pre-embolization of a grade C, a grade B, and grade C. So I think that we must turn both together. We have high rates of complication with endovascular treatment. Most of them some kind difficult to deal, like said Dr. Tatajiba. And when we have hemorrhage from endovascular team treating, is very hard to deal. I saw sometimes you have no time to do a craniotomy and have a good result because it's dramatic case. So I think that it's one point that I like to reinforce, that to treat with endovascular team, we must think that it's preoperative and aim to cure the AVM. Some case endovascular team can do a cure of AVM, like Dr. Boba ask it's a myth or a fact, but I think that is the case that microsurgical has less chance to make damage or to harm the patient. So I think that makes no sense to do with endovascular treatment if the microsurgical can aim the cure and with less risk. And so I think that this must be discussed because endovascular is growing. And I saw many patients, mainly in Brazil, go first to endovascular team and they are trying to do 1, 2, 3, 4 sections of embolization and no aim to cure. For me, it makes no sense. I think that this must be reinforced.
Thank you, Dr. Jorge. Dr. Jorge working in the Air Force. And his boss is endovascular.
He's fired.
Maybe
He's fired.
tomorrow he'll be in jail. Okay. Sorry about that. Rest in peace. Okay. Dr. Guilherme Cabral, want to say something?
I think Dr. Vega,
Dr. Vega, Cabral, and Nicole.
Yes, I have one more question for all. When do you indicate radiosurgery as the first option? And what would you do if it's bleed?
I think radiosurgery as the first option should be for selected small, deep AVMs, where you believe that a surgery may cause some neurological deficit. So for those cases, we can indicate radiosurgery as a first option. But when you have some bleeding, you have to treat the bleeding. If the bleeding is small, you can observe. But after bleeding, the natural history of the AVM, as I have shown previously, is too much worse. So you have to consider operate after radiosurgery because, as we said, we should wait at least 3 years to have some effect of the radiation on the needle. So on this period, you can have some bleed.
Okay.
About to talk with the patient, I think we have 2 simple tools in investigation of asymptomatic AVMs in young people. Rotational and the 3D angiography is very, very important to see bleeding factor risk as direct communication, high flow communications, and intranidal aneurysms, big venous ectasia. And another tool is cognitive evaluation. I think I changed my opinion in some cases after these very simple tools. 3D rotational and reconstruction angiography is very, very important to decide and to see bleeding factor risks.
I think it's the gold standard. I do not operate any patient without DSA. I believe that you have to have at least 1 MRI and 1 DSA.
Not DSA, Jean. The DSA and the rotational and the
rotational with 3D reconstruction. Yes. This is the gold standard for any reason and also for AVMs. You have to have this, of course, if it's available. But if you can decide that this must be the first indication. This is the best exam for vascular lesions on the brain.
We have a commentary here.
Paulo Cadre.
Just wanna say one guy here from Burkina Faso. Burkina Faso, from West Africa. Okay, outstanding presentation. In developed countries, you are a small number as a neurosurgeon. For example, 5 for 17 million, 17 million. Okay, it's difficult to wait for a subspecialty before managing AVM, and there is no embolization. But we try always start for the small AVM and go time by time, get the experience. It's the correct way, no?
Yes, yes.
If you have a small AVM, you have to send to somebody, you never learn.
Exactly. That's
Like
what I
Dr.
said
Rapio say,
previously.
have to center to a specialized center, not a specialized center always. Somebody has to learn, no? What is? Where did you learn, Dr. Rabin? You are the youngest here. I know the Dr. Natal here.
Thank you, Professor Borba. I think this lecture was very interesting. I learned a lot because I know that the radiosurgery and therapy endovascular is just a complement of micro neurosurgery. It's not the option to treat the patient. I think we need to invite more people to make subspecialty in vascular neurosurgery, because it's not the problem only with AVMs. With aneurysm, I saw the same problem. The people think only in endovascular and coil and flow diverter, but I think the first kind of therapy, the cure for patient is absolutely microsurgery. And you are the master of the world. And I appreciate your learning and because you teach us a lot. Thank you so much to everybody.
My pleasure, great honor. Let me ask you, Guilherme. Guilherme,
Eu quero fazer a pergunta para ele também junto aqui.
how do you see these departments that are doing also for Fausto Ferraz? They are embolizing AVM. It's a transvenous embolization. There are a lot of departments doing that, and for me, the way I understand these lesions, for me, it looks like very dangerous. But they are doing that. What do you think about that? What's your feeling about that?
I think I don't.
One second. May I complement the question? The development of treatment of AVM is the same speed as developed the treatment of aneurysm, endovascular. What's the difference in the development of both techniques?
Of course
this
not.
venous and this, okay?
It's the same thing with the microsurgery for aneurysm and the microsurgery for AVMs. So, endovascular venous approach for the AVMs, I think that is a new tool, but very, very difficult and for very, very, very kind of AVM. Rupture, deep, difficult surgery, hard surgery AVMs. A little residue of the AVMs without you can operate or irradiate. So you have some great endovascular surgeons that present a lot of your experience in venous approach with as Professor Chapeau, but in my mind, to get venous approach is not for all AVMs, not for all endovascular surgeons.
Dr.
Selected cases, right?
Jean, isso vai cair, vai ficar vergonhoso como doutor. Dr. Jean, please, you have now is 8:25, supposed to finish 8 p.m. Now you have 2 hours, 25 minutes. Dr. Jean, can you finish this session? Maybe
Yes.
other day you'll come back. Okay. Thank you very much, Jean. Thank you, Professor Colley. Thank you, Fausto. Is your word for the final remarks. Sorry, Fausto.
I have to say that I'm very
Very fast. Go.
Very grateful to be part of this selected neurosurgeons this whole week. It's a great pleasure to share the participation with such a great panelist members. And I would like to thank the Brazilian Society of Neurosurgery for this opportunity, the President Borba, and all the friends from SBN that support us.
See,
on
Dr.
this
Rubino is
project.
still. Dr. Rubino is
this
here,
project.
Dr. Bocanelli is here, Professor Marcos, Dr. Colli is still there with a microphone on. Dr. Vega, thank you, Dr. Vega, Jorge. Tomorrow, 6 p.m. Brazilian time, Dr. Michael Lawton to talk about aneurysm, okay? Wait, everybody here?
Thank
tomorrow,
you very much, everyone.
Same time. Jack, thank you tomorrow. Tomorrow, Jack, bring a very difficult aneurysm to show to Lawton. Let's beat him, okay? Thank you.